and you can convene the meeting. Hold on one moment. All right, we're all set.
Good afternoon, all. This is State Senator Marilyn Moore. We're getting ready. Today is, what day is today? Today is Tuesday.
30th.
Tuesday, this is March the 30th. I don't know where the month has gone. We're going to come to the meeting for Human Services. This is a public hearing. We'll be listening to testimonies today on an act establishing a commission to study a Husky for All single payer universal health care program. Any comments from my chairs? Co-chairs?
No, just welcome to everybody. And just also remember that we had a bill similar to this probably about 8 years ago. So just so everybody's aware. Thank you, Senator.
You're welcome. Representative Case?
No, I'm good. I believe Senator Bertha will be with us shortly once he has his quick ride home from the Senate session. So,
all right then. So we'll get started. So the first person on the list is Jill Zorn. Jill, you there?
Yes, I am.
Thank you, Jill.
Okay. Senator Moore and Representative Abercrombie and members of the committee. My name is Jill Zorn, and I'm Senior Policy Officer at Universal Healthcare Foundation of Connecticut. And I'm here today to testify on behalf of the foundation to convey our strong support for Senate Bill 1090. It's an important step toward achieving guaranteed quality, affordable, equitable healthcare for all in Connecticut. As you know, our current system of healthcare coverage, care, and finance is extremely fragmented and it's broken. Huge variation exists in benefit designs, provider networks, prescription drug formularies, and the prices paid for care. This leads to a system, well, really a non-system, where the United States has the most expensive healthcare in the world, has massive racial and ethnic health disparities, and has higher uninsurance rates and worse health outcomes than most developed countries. And the affordability challenges of our system are so extreme that we have a very high rate of underinsurance too. Even those with coverage are often afraid to use it. We fully support adding Connecticut to the growing list of states, including New York, Oregon, Washington, and Colorado, that are studying the implementation of a single payer system. It's about time that Connecticut joined these ranks. And we're glad to see the provider rates are included in this study. The goal should be one price list to improve administrative simplicity and enhance affordability. But given the extreme variation in what providers are paid now, this will be a challenging implementation issue. So it's important to study. And the study should definitely include a health equity impact assessment. The bill should also explicitly state that coverage for undocumented immigrants would be included. And it should look at the impact of all kinds of jobs, not just those in health or insurance sectors, on the overall cost of healthcare and on the economy as a whole. We'd like to say that the current list of proposed commission members really needs to be augmented with consumer representatives, and we've given some examples, and also someone from the Commission on Women, Children, Seniors, Equity, and Opportunity should be included. Someone from that commission should be included on this commission. Our foundation has extensive experience participating on commissions and overseeing studies of health policy reform. In our experience, funding both for the research itself and for staff support will be necessary if this effort is to be successful. And while this study is happening, we still need to make progress uncovering more people. So I hope the committee will JF SB 956 and 1056 to expand Husky to more people, regardless of immigration status. We urge you to pass SB 1090. I'm happy to take any questions.
Thank you, Jill. Questions? Representative Hughes.
I just wanted to clarify that in the latest language, there is consumer representatives added.
Okay, great.
So I just wanted to note that for the record.
Thank you. Anyone else? Thank you, Jill. Appreciate it.
Thank
Take
you.
care. Next is Allison Weir.
Good afternoon, Senator Moore, Representative Abercrombie, Representative Case, and members of the committee. My name is Allison Weir. I'm a policy advocate with Greater Hartford Legal Aid. I'm here in support of SB 1090 on behalf of Greater Hartford Legal Aid, Connecticut Legal Services, and New Haven Legal Assistance Association. We are fully in support of the bill, but we recommend that the legislature amend the bill to include representatives from nonprofit organizations which provide direct legal representation to low-income Medicaid enrollees, and to include the study of the impact of any program on existing Medicaid enrollees. The Husky Medical Program in Connecticut is a successful and efficient mechanism for providing a wide range of healthcare. And as it has a track record of containing costs that is second to none among health insurance programs in the state. As such, it can be a good foundation to build on which to build a single payer program for all residents, which is certainly a idea worthy of study. Legal Services fully supports the commission to study a Husky for All program. We caution, however, that any study should include consumer advocates, including representatives from those nonprofit legal organizations that work daily to preserve the legal rights of low-income residents to healthcare. Healthcare assistance is a notoriously complicated collection of intersecting federal and state laws, and having individuals steeped in these laws from the perspective of the consumer can only help improve the understanding of and work of the commission as it considers expanding the program to all. While the commission includes representatives from the Health Equity Solution and United States of Care, which are great consumer advocates, they are not legal organizations engaged in the legal pitfalls of getting people enrolled in Husky, ensuring the legal rights of enrollees are preserved, and knowledgeable about how the federal laws and state laws interact to create the programs we call Husky. As such, we strongly recommend representation from nonprofit legal organizations engaged in direct legal representation of low-income Medicaid enrollees. We also caution that any program implemented should not result in less quality and cost efficiency for current Husky residents. Thus, we would add as an additional area study in subsection E, quote 10, the impact of Husky for All single-payer universal healthcare program on existing Medicaid enrollees, including but not exclusively access to care provider networks and other quality measures. Thank you for testifying. Let me know if you have any questions.
Thank you for your testimony.
Thank you very much. Have a great afternoon.
I don't see any questions for you, Allison, but thank you. Next up is Joel Fishman, and I'll be handing this over to my Vice Chair, Matt Lesser, after Joel. Thank you. Joel, are you here?
Senator Moore, I don't think he's here. I think the next person present is Gavin Curran.
Is Gavin here?
Yes, ma'am. Can you hear me?
Thank you.
I'm actually driving right now, so I'm sorry there's no video. I want to testify today in favor of SB 1090. I believe healthcare is a human right, and with that, Connecticut should expand healthcare to all citizens or all people, regardless of income. And I'll keep testimony short. Basically, I want to see it enacted in the state, but I'm definitely in favor of studying the policy first. Thank you.
Thank you. Thank you, Gavin. Are there comments or questions from members of the committee? Comments or questions? If not, thank you very much for your testimony. Please drive safe.
All right, thank you very much. Bye.
All right. Next up, we have Taylor Bidnyars.
Hello, can you hear me?
We sure can.
Yes, awesome. Okay. Dear Senator Moore, Representative Abercrombie, and members of the Human Services Committee, my name is Taylor Bidnyars. I am from Ellington, Connecticut, and I support Senate Bill 1090, an act establishing a commission to study a Husky for All single-payer universal healthcare program. A single-payer universal healthcare system would make healthcare equitable, dependable, and affordable. Our country is horrendous when it comes to healthcare. I am turning 25 this June, and I am paralyzed by insomnia most nights thinking about what happens next year when I turn 26. I work in this field, actually, politics, but with no degree, it's mostly seasonal, which I'm okay with, but it's not like those jobs come with benefits. I want to briefly mention a few things that have impacted me. I've sprained my ankle 3 times in one night. The doctor said it actually would have been better if I had broken it. But I waited until the morning to go to an urgent care, as my copay for that is far cheaper than going to an ER, even though I was in a lot of pain. Over a month ago now, My dad, who, if you know me for more than 10 minutes, you know he is my best friend, he had a heart attack. Thankfully, due to quick medical care, he's doing fine. But the second thought after making sure he was okay was about money and the cost. And while it shouldn't matter, he has a very decent job. Thirdly, I breathe through my mouth. I haven't been able to breathe through my nose since I was 6 years old. That doesn't seem important, but it makes me more vulnerable to cavities, which I cannot afford. And I don't expect my parents to always pay for my copays, so I stopped going to my dentist 3 years ago. When I can actually afford to go again, they will probably be root canals. Lastly, I have been depressed since I was 11, in therapy since 15, on medication since 17. I've dealt with anxiety, cutting, other forms of self-harm, and my therapist has basically saved my life. My therapy has gone back to once a week, which is a $25 per copay. That's $100 a month and $1,200 a year. It may not sound like a lot to some of you, but to me, it is everything. And the root of my fear for next year is if I can survive without it if I have to. Basically, every other civilized country does this, and there's no excuse beyond capitalism and greed for why we do not. I know that there are lots of facts that others may testify with, but this is my life, and one life is worth more than all the profit. I am ashamed that our country hasn't realized this yet. I hope you pass this study bill. Thank you.
Thank you, Taylor, and thank you for having the strength to tell your story. I know is a story that we've heard from you, but I think we're going to hear similar stories from other people here today about why healthcare is so important. Just speaking personally, you know, I've gone through medical issues in my past, and I've been very lucky because healthcare is hard enough without having to worry about how to pay for it. There's a lot we've got to figure out. So thank you for telling your story. Are there comments or questions from members of the committee? Yes, Representative Hughes.
Thank you, Taylor, so much for your testimony. I wanted to know if you had some ideas in terms of this study that, of course, we're looking at a Husky for All that covers vision, dental, hearing, behavioral health, physical health, and long-term care. Do you think that from your experience in outreach and activism that we have the political and public will to seriously look at this now?
I definitely think that we do, and thank you for your question. I definitely think that we do. I think even before this pandemic, that if you look the Medicare for All or single payer healthcare system, the popularity has been rising for that every single year. It gets more and more popular. And it was especially talked about in the 2016 presidential election. And then it seemed like every candidate was talking about it in the 2020 presidential primary, when only one was talking about it in 2016. So we're seeing it become more popular, more candidates are being on board with it. And I think especially now that there's been a pandemic and, you know, nationally, internationally, this is the time to do this. This is the time where it makes the most sense to really try to get this done.
Thank you. That's all I had.
Thank you.
Thank you.
Other comments or questions from members of the committee? If not, thank you for your testimony.
Thank you.
Next up, I don't think Pearl Granat is on the line. Is Pearl with us? How about Cynthia Tun? Kathy Flaherty? Deb Cohen? I believe we have Holly Hackett, and Holly Hackett will be followed by Claudette Kidd, unless some of our previous speakers. Holly, you're up.
Okay, thank you, Senator Lesser. Senator Lesser, Senator Moore, Representative Abercrombie, and distinguished members of the Human Services Committee. My name is Holly Hackett, and I live in East Haven. I am a community advocate for Mothers and Others for Justice and Health, which is helping everyone achieve lifelong trusted health care, Medicare for All Connecticut, and I am a community liaison with the Enrich Lab at the Yale School of Public Health. I stand in support of SB 1090, an act establishing a commission to study a Husky for All single-payer universal health care program. It is imperative that the Committee on Human Services vote this Senate bill out of committee joint favorable so the bill can progress to the next stages of the legislative process. I will tell you my stories. It's more important to me. You have all the data, you have my written testimony. My mom had a brain tumor. It was the size of a softball. It was removed a few years back. She still currently has an aneurysm, and she was supposed to get MRIs done every 3 months. Her United Healthcare Advantage plan denied approval for that. Her doctor changed the orders, then for every 6 months, still denied. Finally, her 1-year MRIs were approved. And in my opinion, this is not just absolutely immoral, it is criminal. I did call the Office of the Healthcare Advocate to try to help out the situation, but my mom would not let me go any further. But yet, when she told her surgeon's office that I reached out to OHA on her behalf, she never got denied again. I just thought it was a little odd. In my case, when I was determined eligible for Social Security disability, I had to wait 24 months for Medicare coverage. And in that time frame, I did not have any insurance because my income was too high due to the lump sum payment from Social Security. It is a ludicrous way of calculating salary and completely unfair to leave an extremely vulnerable person with major health issues and no health coverage for 2 years. That's unacceptable and should never, ever happen, and it needs to change. I lived in elderly disabled housing, and I helped a lot of my neighbors who were being completely preyed upon by insurance people to purchase Medigap insurance when they never needed it because they all qualify for Medicare savings programs. So it was just horrendous, and it happens all the time with the elderly and the disabled, and that needs to stop. If a single-payer universal health care program is put in place in Connecticut, we would not have to worry about predatory for-profit insurance companies going after our most vulnerable populations, such as the elderly and disabled. We would also never again have to worry about maintaining our employment to keep our medical insurance. We in Connecticut have some top-notch healthcare facilities and medical school programs, yet we have some of the worst outcomes than any other industrialized nation. Our current system is broken, and if the federal government cannot fix it, we here in Connecticut must. Instead of being the insurance capital of the world, we should be the healthcare capital of the world. We have the nurses, doctors, trained support staff, mental health experts, hospitals, and universities. We just have to dismantle the broken, out-of-date, usually racist, bigoted, misogynistic, for-profit healthcare system and have a new way of doing things where everyone is truly treated equally.
Excuse me, your 3 minutes are up. Please summarize.
I'm ready. I am right now. I appreciate your time and consideration and hope you vote joint favorable on SB 1090 so that Connecticut can become a shining star of the healthcare world and our population will be the healthiest, most productive with a bustling economy. Thank you so much.
Thank you, Holly. Are there comments or questions from members of the committee? Representative Hughes.
Thank you, Mr. Chair. Tell us how you really feel, Holly. Would you say something around, I know you have looked into the economic analysis and the cost savings. Would you say something about what you hope this study independently verifies?
According to Professor Rodberg, it would save $1.475 billion for Connecticut, and that's 2.9% of the annual budget. And that was done based on calculations from Professor, I keep getting their names mixed up, and that's in my written testimony. My apologies, I'm trying to search for it now. I apologize, Rep. Hughes.
No, that's okay. I wanted to pivot to the economic analysis portion, which is so critical to study, making good policy going forward. We have the vision, but can we get the economic data to make the vision real? That's
absolutely. It's absolutely 100% possible. And there has been an economic study done based on the professor who is known very well to do economic impact studies, Professor Friedman, I believe. I apologize, Rep Hughes. I did have it right in front of me, and I am now nervous and flipping through everything. Okay.
No, that's okay. That's okay.
Professor Gerald Friedberg is the professor who is known for the studies, and Professor, so 1.475 billion, 2.9% of our annual budget. My apologies, Rep Hughes.
Great, thank you. Yeah, and that's, I know, I think I saw that in your testimony.
Okay, yeah, again, my apologies.
No, it's great, that's great. I don't have any other questions, Senator.
Thank you, Representative Aurora.
Thank you, Mr. Chairman. And thank you, Holly, for your for being here. I have a couple of questions. One, I wanted to really ask you about your specific experience with the system, that when you were making more money, they wouldn't cover you. And I'm assuming Medicaid or Husky wouldn't cover you. Is that right? Right? When you go above a certain income. And
well, go ahead. I'm sorry, Rep Aurora. What happened was when you finally get approved for Social Security disability, you are given a one lump sum payment. So that's for all of the years that you had no income coming in because you weren't working because you were disabled. But the process takes so many years in order to get approved that you have no income coming in. So when you are finally approved, you get a lump sum payment for all your prior years of back pay. So that's
so during that 2 years when you were not, when you were making too much money, that you wouldn't be approved, you said. You said 2 years you were not covered by Medicaid Husky because you were making too much money.
No, when I was approved, as soon as I was approved for Social Security disability, you get a lump sum payment paid to you. So as soon as that payment hits, you have a 24-month waiting period for Medicare to kick in, but you also are not eligible for Medicaid because of your lump sum payment from Social Security disability.
But during that time, does the ACA program available to you?
Oh, yeah, sure. If you want to pay $500 a month because of your determination of your lump sum payment and you want to pay a huge deductible, sure. It was less expensive for me to pay out of pocket and to cut down on medications and to cut back on my doctor's appointments than it would have been for me to go on the ACA. It was horrifically and horrendously expensive.
So one of the things you would testify is that the ACA is a broken program and is really a failed system. And as a result, we need some other solution, which we should study. The ACA, which basically was put forward as a be all end all, is a total failure. Would you agree with me?
I don't think I would say that it was a total failure, but I am not an expert. I'm just saying what happened to me. I cannot speak for everyone, but I am speaking for myself. So I would not say
it did not work for you.
To that. Correct. It did not work for me in my situation.
Because, because and I just want to understand this well, that it was $500 a month, which is $6,000 a year of premiums, and I think it is about 5% of your income at that point or something like that, limited to 7%. And your point was, well, the Husky program is so much better because you have zero premiums. And, just because you're making a little more, you shouldn't be forced to pay 5%, which is about $500 a month. And that's just unreasonable. And we should study a different system.
I believe so, but I think what you're failing to understand, or it might be a miscommunication, Rep Aurora, is the fact that it is not my income, my monthly income that I had. Yes, that one time. Yes. Okay, please. I didn't want to misrepresent anything or any part of my testimony.
No, I'm not saying that. I'm not saying that.
Okay.
No, I'm really learning here because this is one of the objectives is to learn. And so, one of the real questions we normally have with the ACA, and really, we're looking for from both sides of the aisles, perhaps, and more from my side of the aisle, we really do believe that the ACA has done us really a big damage. And it has really taken the middle class out of. And when I really pointed out is, which really, thankfully, you pointed out that when you get to make a little bit of money, and in your case, one time, the ACA just destroys you because suddenly you get to pay $7,000, $10,000 in premium.
And I don't believe it. The problem is that it's the for-profit insurance companies that are ruining it. It has nothing to do with the meaning that the ACA was set forth to do. It has to do with the for-profit insurance companies. That is it. It's not the meaning behind it. It's the people who deliver it, meaning the for-profit insurance companies.
So are you only implying that it's the for-profit insurance companies, or even the other hospitals, for-profit doctors' offices, for-profit hospitals should also be? What about for-profit surgeons' offices? They are all also pretty bad people.
I'm saying to you, it is my opinion that our healthcare coverage should not be bought and sold and traded on the market. That is not what I want for my healthcare. Nobody should ever put a price on my life and my health, and it should never happen, period.
No, I really do appreciate your input, because we need different points of view, because, some would say that similarly food and shelter are extremely important, and they should also be taken over by the government and provided by the government. Perhaps, would you care to comment if you'd like?
No, that is not part of my testimony today. You can contact me at any time you'd like to discuss that at a later date, but that is not part of my testimony today, Representative Aurora.
I thank you for your time. This really helps us understand, a point of view which you bring to the table. Thank you, Matt. Thank you, Holly, and thank you, Mr. Chairman.
You're very welcome, Rep. Aurora.
Thank you, Holly, and thank you, Representative. Other comments or questions from members of the committee? If not, thank you for your testimony here this afternoon.
Thank you so much. Have a great day.
You too. Next up, we have, I believe, Claudette Kidd.
Yes.
Followed by Cameron. Good afternoon.
Good afternoon, Senator Moore. Oh, sorry.
I'm not Senator Moore, but that's okay. She's the chair of the committee. I just work for her.
Okay. All right. I'm sorry for interrupting. Let me know when I can go. Okay. Good afternoon, Senator Moore, Representative Abercrombie, and members of the Human Service Committee. My name is Claudette Kidd, and I reside in New Haven, Connecticut. I stand in support of SB 1090, an act establishing a commission to study a Husky for all single-payer universal healthcare program. In that system, it takes responsibility for financing healthcare for all residents. That is, everyone has health insurance under one health insurance plan and has access to necessary services, including doctors, hospitals, long-term care, prescription drugs, dentists, and vision care. Individuals may choose where they go to receive their care. This bill would create a commission to study the potential for a single-payer system in Connecticut. Therefore, it is very important first steps towards charting a path to a statewide single-payer health plan in Connecticut. In this current system, I feel imprisoned and not in control of what physician I can see who can help me with my ailments and recommend treatment that actually works, instead of me chasing my tail trying to get well and lower my problems with pain management. Therefore, this causes more stress, high blood pressure, possible PTSD, or not attending my appointments at all, leaving no trust in the current system. The cost of medical care would go down significantly if it was financed by taxation and not by premiums. Roughly 1/3 of healthcare dollars spent in the US goes towards administrative costs rather than on actual healthcare. Single payer makes fiscal sense. If we are to implement the taxation process for people and employers to pay into, just as they do currently for profit commercial insurance plans, as my fellow friend said, Holly Hackett, it would save the state of Connecticut approximately 2.9 net savings. And that is a savings of $1.475 billion. And this is according to Professor Rodberg. It would establish a true free market system, turning the tables around to where doctors now compete for patients rather than health insurance companies dictating which patients are able to see which doctors and set in reimbursement rates. It would also prevent insurers from maxing out your insurance and your ailments have not improved at all. For example, having few or no teeth left, because rather than help save a tooth or teeth, the dentist would rather pull them out or offer services that cost way over $1,000 or more, which most of us cannot afford. Meanwhile, we're struggling with housing instability, food insecurity, and can barely pay rent and utilities. They need to take a walk in our shoes. Throughout New Haven, I see many people with missing tooth, and I say to myself, there goes a possible person who the system has failed.
Excuse me, ma'am. Your 3 minutes are up. Can you please summarize? Thank you.
Yes, I sure will. Guaranteed equitable coverage for all is what we need, including dental, vision, etc. Healthcare is a human right. We need Medicare for all, included for undocumented immigrants. We need SB 1090. Thank you.
Thank you, Ms. Kidd. Thank you for your testimony this afternoon, and appreciate you being here. Yes, Representative Dathan, do you have a question for Claudette Kidd?
Thank you, Chairman Lesser. Hello, Claudette. Thank you so much for your testimony today. I'm guessing from your accent, you are from England.
Yes, I am.
Okay, so I spent a quarter of my life in the UK, and I sort of loved the NHS. It worked really well for me. And I was hoping that maybe you could speak about some of your experiences with the NHS. I know it's not a perfect system, but you talk about a single payer option in the US, which I'm not 100% supporting, but I really think the NHS worked for the UK. Can you describe maybe a couple instances where it's worked for you and your experiences?
I feel that a few decades ago, the NHS system worked very well because you could select what doctor you see. It didn't matter what area you lived in. And it was more of an open door policy. And currently the NHS system is sort of like, they've tied your hands because you can only see the doctors in your area, within your postcode. You cannot go outside your postcode. You have to call in for an appointment, which sometimes you have to call in within 15 minutes, I believe, to make an appointment. And during that time, a lot of the appointments are taken and you're missing out on an appointment. So it's a call-in system. And then this makes people having to wait days upon days to get an appointment because of this call-in system. You're allowed 10 minutes with your physician before they put you out. So it's not a system where you can talk freely and there's a bit of care and a bit of compassion. The doctor may barely look you in your eyes when he's talking to you, and it's not a good relationship. But in the past, I feel that it did work. It was going really, really well. Change of governments changed the medical system. The NHS in Canada seems to work a lot better than in the UK. So I would look at the NHS system in Canada.
I guess it was with the change in governments when it became a Tory government is when it kind of all fell to bits because I gave birth to two kids under the New Labour, Tony Blair government, and it was completely different. And even as that government changed over to other Labour members, it seemed to be going really well. But I've been in the US for about 15 years now, and it's changed, it sounds like, quite a bit. But thank you for that. And I do think for me, I think having having options and choices for people so people can choose whether they stay under their own healthcare coverage, whether it's through one of the providers in our state or in others, or have a public option. And a Husky expansion is what I'm really focusing on individually, because you pointed out rightly in your testimony, having that access to healthcare, the preventative care is so important, because the preventative care actually saves money. And in my experience in the UK, I had excellent preventative care. I did, when I first arrived in the UK in the early 90s, it was, I had my own private insurance, but then I ended up switching over to the NHS because I got so much better service. Yeah, and but I appreciate your testimony, and I think it gives some insight for someone who's seen both types of medical systems in action, to be able to understand that. So thank you so much for coming out today, and have a good afternoon. Thank you, Mr. Chairman.
Thank you. And it does help when you have a comparison of two totally different medical systems, because then you can actually see with a broader angle exactly how the systems work or they don't work.
Quite right. Thank you.
Thank
very
you.
much.
Thank you, Representative Hughes.
Thank you, Mr. Chair, and thank you, Claudette, for your testimony. There were two things that you said that I just wanted to follow up on. You said something about restoring credibility of our healthcare system, and Representative Dathan touched on the preventative care, especially since now we have so much insurance denial and anxiety over the cost. So we're looking at 3.5 million people in this state of Connecticut. So we're looking like a tiny little community, that everybody in that postal coverage would be. We're looking at studying it, like what it would really take, and also, what would this little free market system look like within our state and our 3.5 million people. In your experience, do you think there would be people that would go ahead and opt for a platinum, or like a really gold standard plan on top of, to cover what the preventive care, the basic care, the people who can afford to might purchase an additional plan, sort of like a Medicare Advantage plan or something? Do you think that
most definitely, if you can afford to, right? That would more than likely be the middle class people and up. But as for working people as myself, we would be happy with just the plan as it is. Hopefully, we don't know yet because we haven't seen what it actually looks like. It hasn't piloted, the bill hasn't passed. So that's something that we hope for.
But in your experience back in the UK, did people purchase, additional coverage if they could afford it?
I know for a fact that my sister did. And in that instance where she needed surgery. And what had happened was she used her private insurance on top of the NHS insurance to get the date moved forward. And in that instance, it worked really well for her.
Great, thank you. Thank you, that's all, Mr. Chair.
Thank you very much.
Thank you, Representative Hughes. Representative Aurora.
Thank you, Mr. Chair. Thank you, Claudette. I really appreciate you being here, because you bring what very few people here bring to the table, which is having seen both two systems side by side. And as you said, it started out really well about 20 years ago, and then there were some problems with the other system, or a socialized system, or a communist system out there. A socialized system, sorry, I shouldn't use the word communist. A socialized system. My question to you is, do you have experience with the Husky program here as well as the NHS program?
Yes, I do.
So the Husky works very well. I didn't know you had used Husky, you had subscribed to Husky or to an ACA program. because, many of us here use either employer paid or ACA program as well. Now, this is the question because I just give a very quick experience I had with NHS. My aunt who lived there was denied a heart pacemaker because she was 72. She ended up developing a very serious condition and had a really poor outcome, which took 4 years because they would say that after a point in time, she was not eligible to get a pacemaker replaced. She was 72 or 73. So, so I am very opposed to NHS after that experience. I told her, please come over here, please come to the US and you can, and she could afford it, but she was part of the NHS system. So my question here is that could you see that deterioration of services could happen to the current Husky population if we added everybody? Would you worry about that? Because that's what happened in UK. That's what happened, and actually Canada is pretty bad these days as well. Just like what you said, you don't get enough time. Do you think that's a possibility?
How long ago was it when your aunt was denied the surgery?
It's about 6 or 7 years ago.
Yeah. Yeah, that's when it was bad then and it's even worse now. I think that was because of a change of government. And
it was Blair at that time, I think was Blair. And I think the NHS, I think these programs, let's just keep the politics out. The question which I have for you really is that you've seen a system deteriorate, right? And we have a Husky program which is working pretty good. Would you not, I just worry, and I just want to share if you would worry about it. You have a Husky program which is working good. You have seen other systems which start good and then just crash and burn. And so let's just keep something which is working the way it is, rather than expand it to the entire universe, including one of our other, person had suggested that even for older people, which is basically Medicare, which is another program our seniors love. Our seniors love Medicare, right? And I think to take away Medicare is, again, not a good idea. So I'm asking, my question really is that as a Husky user, don't you worry that you're going to expand Husky and see it go the NHS way?
It can't be any worse for me than it is now. Right now, I need to go to the dentist. And when I go to the dentist, rather than fix my teeth, they pulled it. They want to pull another 3, and I totally deny. I'm in the process of saving up money to pay for for the betterment of my teeth, rather than them pull it. I said in my statement, I think, or I didn't get there, that if you take a walk around New Haven, you'll see many, many, many people with missing teeth. And this is because they can't afford to get either a bridge or an implantment or anything like that. So, and then even sometimes to have a cavity done, you can't get that done. So rather than some dentists do preventative work or build up on your tooth so that it's a lot better, they'll pull it.
Oh, so you're saying the Husky program is also
give you dentures that doesn't fit right, that they're too tight or too loose, or they're causing bruising on your gums, and don't do anything to fix it.
So, Claudette, I really would want to, maybe I understood you wrong. I thought you said you are availing of the Husky program. So you think the Husky program is really bad shape even now already? Is that what you were saying, that it doesn't cover?
It depends. Like, for instance, like I said with my teeth, I can't afford over $1,000 to get my teeth fixed. And if it was one where I could maybe pick where I go for a dental treatment, maybe they may put me on a plan that may work for me, that I can keep my smile. Whereas right now in the system, it doesn't work for me. It doesn't work.
So what you're, finally, what you're trying to really say, I think this is a really important point you're making. I really appreciate you doing so, is that the Husky program needs to be improved, because the current Husky is pretty bad as well in your mind. And, we need to work on here you are asking us as as your legislator to work to improve the Husky program so it's a little better, let alone, just diluting it further. Would that be a correct statement?
We need to improve medical for all, period. Like we don't have much choices, much say in what happens with our medical. I can go to a doctor and complain about my back, and unless he sees me in tears crying, he's not going to do nothing.
Yeah, no, because we have, the way we think about it is you have Husky for those who, for certain people making certain threshold. Then you have ACA or the Obamacare if you're making above a certain threshold. And then if you're older, we have Medicare. So that's the trifecta of programs we have: Husky, Obamacare, or ACA, and then Medicare. And each one has its positives and negatives. But I'm glad to have your point of view that at least from a Husky is pretty broken. That's what you're saying. We hear good things about Husky quite often as well. But I appreciate your input. Thank you very much for taking your time.
There's good and bad. There's good and bad, no matter how you look at it.
Yes, no, I appreciate your input. This is a lot of things in life. We always have to try improving. So thank you. Thank you, Mr. Chair, for giving me the time. Thank you.
Thank you, Representative, for your comments. And Claudette, thank you for sharing your story. And for your story and your perspective as well, comparing different systems in different countries. And I agree with the point that you made earlier that it's important for us to break out of a shell and see other systems of delivering quality care. So thank you for being here today.
Thank you.
Next up, we have Cameron Kessler, followed by Matthew Meislish.
Can you hear me?
We can.
Awesome. Good afternoon, esteemed members of the committee. My name is Cameron Kessler. I live in Hartford. I'm a Master's of Social Work student here in Hartford at UConn School of Social Work. I'm a social work intern at Connecticut Citizen Action Group, and I'm also a children's librarian. I speak on behalf of myself and CCAG today in full support of SB 1090. First, I want to tell you about my own insurance experience. Some of you may have actually heard this story when I testified on behalf of SB 842, but I'll tell you anyway. I received my health insurance through my parents. While I'm lucky to be on their insurance, obviously it doesn't provide me with adequate health care. My family's deductible is $5,000 per person, so that's $15,000 a year for all three of us to be covered. I don't have ongoing health problems, which means I don't normally meet this deductible, so when big things happen, it happens all at once. So in June of 2020, I had a routine but emergency surgery. I had to get my appendix removed. Even though I have insurance, I had to pay $5,000 out of pocket all at once for this surgery. I only work part-time because I'm also a full-time graduate student, and I just finished paying these expenses off almost a full year later. And due to this low-quality health insurance, I tend to avoid seeking out healthcare unless it's an emergency like my appendix last June. And many others in the state are in the same situation as me. And during a global health crisis like this, it can't be the case. This is going to keep happening for a long time. And when people don't seek out healthcare when they need it, the consequences are life and death. Husky for All would literally save lives. Secondly, I also want to point out that in 1992, the Public Health Committee, chaired at the time by Congressman Joe Courtney, commissioned Lewin, an independent corporate consulting firm, to develop a plan for Connecticut, anticipating that Bill Clinton would pass healthcare reform. That healthcare reform was nicknamed Hillary Care. Obviously, it didn't pass, but the study concluded that if Connecticut were to adopt single-payer healthcare, the state would save $7.7 billion over the course of 10 years, and that was in 1990. So we're experiencing a public health crisis unlike anything we've seen in the past century and maybe longer. Now more than ever, we need to ensure adequate healthcare for all of Connecticut, not just those who can afford it. And not only that, switching to a single-payer healthcare system has already been shown to make economic sense in this state. This avenue needs to be explored again, and we need to start now. Thank you for your time.
Thank you, Cameron. And you're right, some of us do double duty on a couple of different committees, but it's good to see you again, and thank you for sharing your story. Are there comments or questions from members of the committee? Yes, Representative Hughes.
Thank you so much, Cameron, for your testimony. And I have heard these catastrophic stories before. Just to sort of piggyback on our last testifier, you know, one of the things that Connecticut tries to do is expand what's covered under Husky. So I don't know if you've been on Husky or know of anybody, but like children's dental, we do pretty well with preventative care. We don't do well with covering, even if you do qualify for Husky, like some of the things that we were talking about with, you know, the root canals and the cavities and the more, you know, serious things that can turn into infections and be catastrophic. And that's why it's so important that even in 1990, if we looked at what it would cost to switch to a single payer, which is really eliminating so much of the administrative costs, that middle for-profit thing that we talked about, but also just covering the services, just you know, a rate of reimbursing basic services. How long do you think it would take for our population, especially young people like yourself, to just start catching up on using preventative care and routine care and preventative care? How long do you think that would take if you were suddenly covered by a you know, like a robust Husky for All, which is why I keep saying it's got to cover dental, vision, hearing, behavioral, and physical health, as well as long-term care.
I mean, I think this would be a cultural shift. My whole generation, we're just under this idea that we can't afford healthcare. I don't know anyone that goes to the dentist twice a year. It's like almost laughable to think that you would go 2 times a year just for preventative care.
Wow.
I don't know anyone with a GP. It would, I mean, it would change our society forever if we had this kind of system.
So you're basically of a generation that just avoids contact with the medical healthcare provider.
Absolutely. I mean, I even think, you know, you hear these things. It's like, if it's an emergency, don't call an ambulance. If it's an emergency, like, call someone who can drive you to the ER, because we can't afford ambulances. So this would change everything.
Wow. Thank you. That's very powerful. Thank you for your testimony.
Thank you.
Representative O'Rourke.
Thank you, Mr. Chair. Thank you, Cameron, for being here and for providing your point of view. My question for you is that did you explore taking advantage of ACA, you know, also known as Obamacare, you know, when you became, you know, when you went to graduate school? Because technically Obamacare does, or ACA, you know, I'll refer to it as ACA, but many people do not really, you know, like referring it to Obamacare. I like ACA more. You know, if you really explored that.
So I didn't know why I should explore it. I mean, I have health insurance, right? I am insured via my parents. I can afford the copays, I mean, not the copays, the premiums, but then I can't afford the health insurance that it provides for me. I've actually been exploring applying for Husky because I am actually eligible. However, I do not want this to be a dig at Husky, because I think Husky is a very good system. I think it just needs to have more funding and more attention paid to it. But I tried to apply this week for Husky and the website is currently down. So I would like more money put into Husky so more people can be able to get this kind of healthcare.
So what you're saying is that you know, the reason I asked you is because $5,000 deductible is not a reasonable deductible for anyone, right? For anyone. So I feel very badly that you were that anyone, you know, and you are a standing example, had a $5,000 deductible. It's different if you said $500 deductible or $1,000 deductible, or 5,000 is just out there. So my question is that most of in the case of ACA, you know, you would qualify because the ACA really makes your premium dependent upon your income. So if your income is X, it will be especially right above as a graduate student, uncle, unless you are a, Yale Law School graduate student. I don't know where you go. Your income would be such that you would pay 1 or 2% or 3% of your income, which would be a few $100s of premium. So my question really is that, one thing we have to ensure is, irrespective of how good programs we have, if we cannot communicate and have everyone take advantage of those, right, then the programs are not good. And secondly, that's the reason I asked you, because that predicament which you had was a tough one. It was hard to hear. But, I do want to point out to you that there are programs out there already, ACA in this case, Husky, if you're eligible for, that's another one, which would provide those. Now, secondly, I want to ask you a little bit about what you have heard about Husky, because, we've spent a lot of time, and we spent a lot of time discussing various elements about Husky. And, you just mentioned that Husky needs some improvement. Do you have any more thoughts on that?
I would like to talk first about what I've heard about Husky. As mentioned, I'm 24. I know a lot of people on Husky, my generation. Most of the people I know on Husky absolutely love it. My roommate was on Husky, and she was able to get 2 surgeries completely free to remove tumors. I have a friend who broke both of her ankles and got physical rehab for it. What is it called? I can't remember. But
PT,
and they have just loved the kind of healthcare that they have been receiving on Husky. And it's hard not to feel jealous at times, because on my independent insurance that I am receiving, I am not getting that kind of healthcare. It's not the same kind, and that's not okay. And you're asking if I've looked into other types. I am actively looking into them, but I shouldn't have to. And also, my family is not eligible for ACA and not eligible for Husky, but they're still having to pay these $5,000 deductibles every year. And that's a lot of money, even for people who are not eligible for ACA or Husky. It's a ton of money. And I don't think anyone in America should have to pay $5,000 deductibles. And you mentioned earlier that why break a system that is already working? I would argue that the system is not already working. The system is pretty broken.
So would you suggest that the Husky system is broken as well? What you're contending is that the Husky system is working, everything else is broken, and Medicare system is working perhaps, because, I hear our seniors say really good things about Medicare. So what you're saying is Husky and Medicare are working and everything else is broken. Would that be your contention?
Yes, private insurance is not working.
So private system is broken. And would it be possible that it's working because it's very limited in scope, that if you really increase the scope of it, that would break too? Because just what we heard about NHS, because we do not live in vacuum, right? What is good for other countries, for example, UK, Canada, all the folks try to buy private insurance on top of it, which is more expensive than the basic thing itself. And then in going on to maybe Russian system or the Chinese system or perhaps the Iranian system, those systems are more government controlled system. Do you think that the government controlled system on healthcare and perhaps maybe later on food and shelter would be also a reasonable way?
I mean, I don't know enough about international healthcare policy to answer that kind of question. I only know what I see in my community, and I see that we are not getting the kind of healthcare that we need.
Got it. Thank you very much. I really appreciate your input. Thank you, Mr. Chair.
Thank you, Representative. Representative, if you have information on the Russian or the Chinese or the Iranian system that you want to share with this committee, I'm sure the members would be interested in seeing it. Are there other comments or questions for Ms. Kessler from members of the committee? If not, thank you for sharing your story, and I'm glad you're doing better. It's the terrifying story. So thank you for being here. Next up, we have Matthew Meislish, followed by Daniel Bryan, followed by Karen Siegel.
Thank you, Senator Lesser. Thank you to the committee. My name is Matt Meislish. I'm in my final year of the MD-PhD program at Yale School of Medicine. And I want to start by telling a very brief story. One of my patients who I saw regularly in the Yale Primary Care Center had severe heartburn, which of course is quite common, and developed difficulty swallowing. That for us raises alarms because it can indicate the development of esophageal cancer. And esophageal cancer has a mortality rate of about 80% in 5 years. The way you prevent that outcome is to detect the cancer early. And the way we do that is with endoscopy. So we directly visualize the esophagus to see if there's cancer. The problem was that this patient didn't have health insurance. He was an electrician. He made a decent income. He wasn't eligible for Husky because of his income, and he wasn't able to afford private health insurance. So he opted not to get the endoscopy. It was too expensive. We don't know if he had cancer. The right thing to do would have been to test for it. And if he did have cancer, we almost surely missed our window of opportunity to actually intervene and save his life. That story, unfortunately, is commonplace. I mean, every physician that you speak to, every healthcare provider will tell you stories just like that, because there are so many people who fall through the cracks in our current healthcare system, and for whom we can't provide the right kind of care. And those are just the patients who actually come to our attention. So I've been in the MD-PhD program for 9 years, which is enough time to have a good sense of a lot of the problems that exist because of the structure of our healthcare system. But I'm beginning residency next year, so I'm early enough in my career that I feel optimistic. I feel that we can carve out the kind of healthcare system that actually serves our communities, and in which we have, myself and my colleagues have signed up to participate in. We went into healthcare because we believe in serving our communities, not in serving people who can afford health insurance, and not in dictating our care based on the incentives that are driven by our current health insurance system. So in that vein, over the last many years, or starting in 2009, I've been advocating for legislation in Connecticut that would increase access for a number of people who are currently excluded, beginning in 2009 with Sustanet, which of course would have provided a public option. And most recently this session for SB 956 that would extend Husky to immigrant communities, which of course is in this Human Services Committee. But I want to make the point today that those are basically, we're plugging holes, right? Those are holes in the ship, and we are plugging them as fast as we can. And it's critical to do that work. It's critical to plug those holes and to get health insurance and healthcare access for as many people as possible.
Excuse me, your 3 minutes are up. Please summarize.
Thank you. But in the end, what we need is to think about how to rebuild the ship, how to build it in a way that actually includes all members of our community and that can allow us to steer our healthcare system in the right direction toward care that's compassionate and humane and lower cost and sensible. And that's what I believe this bill will allow us to do.
Thank you for your testimony. Can I just because you've testified on a number of bills and you've been studying these issues, obviously I hear you articulating a need for universal health coverage. At least that's what I understand you.
Sorry, yeah, I should have specified. SB 1090 is the bill that I'm testifying in support of today.
No, I understand. I understand. That's the only bill on the agenda. Okay. I hope so. Otherwise, you're in the wrong hearing. But in terms of the specific goal that you're looking for, I understand you to be asking us to move forward universal health coverage. Is that right?
That's right.
Okay, so the reason I'm asking is because the specific proposal that I understand this bill to entertain is a single payer proposal. There are different countries around the world that have gotten to universal coverage through a variety of different mechanisms. Germany, for example, has a multiple payer model, but they have universal coverage. So I don't know if are you locked into one way to get there? Are you open to multiple different sort of avenues to get to the goal of universal coverage?
Yeah, I mean, I believe that a single payer system is probably the best approach for a number of reasons, including, the economics of, health insurance and increasing the size of the pool and allowing, the distribution of risk that comes with that, as well as the ability of that single payer to create incentives that lower cost, and to make sure that there is truly universal access. But no, I don't actually think that I'm locked in personally to a single approach to achieve universal access. I believe that the ideal approach would both create universal access and restructure some of the incentives that in our healthcare system that drive such high costs.
Thank you, Firucar. We've got a familiar duo here, Representative Hughes, followed by Representative Aurora.
Thank you, Matthew. And thank you, Mr. Chair. I'm really interested in where you feel the medical community has moved in terms of plugging, from desperately plugging holes, especially in the wake of this pandemic, to quickly constructing another ship. Do you have you, in your 10 years since you've been, in this sort of setting, have you seen the public will change from the medical community?
Yeah, absolutely. I mean, I think that our generation of healthcare providers has a very different attitude toward the purpose of our healthcare system and the right approaches to our healthcare system than previous generations did. I think that it's a combination of selection for who is going into medicine, and also, I imagine that Representative Aurora might ask me about the ACA, and there's a lot to say about the ACA, and I've been quite involved in advocating for it to remain in place in the last few years. But one of the things that it did was change the standard, right? Before the ACA, we thought that it was okay for health insurance companies to exclude people based on pre-existing conditions. No one thinks that's okay anymore. The ACA changed what we expect from our healthcare system to be that everyone would be covered. And the deficiencies in the ACA are its inability to do that because it works through a private health insurance system. And so it is flawed for sure. But I think that even the flaws that we're discussing are evidence of the fact that our expectations of our healthcare system have changed. And I have been involved in mobilizing medical students and young trainees across the country in support of universal access, through the ACA and through additional means. And I've seen how much momentum there is behind that movement. I think that is an emerging consensus among the medical community.
Thank you for that. And through you, Mr. Chair, I think what I'm really hoping is, I'm hearing from a number of younger, generation people that say they would never, even nobody that they know goes to preventative dental care twice a year, and that is the opposite of my experience at your age, the opposite in terms of maintaining. But then again, there were a lot of my counterparts that went their entire 20s and the entire 30s having no coverage and just hoping that they had no catastrophic. But now, since we pushed everything into the catastrophic and unavoidable, and the concept of medical debt, which didn't even really exist, a generation ago, and now is the norm. I find it really interesting what you're talking about in terms of changing expectations, both of the healthcare system, of the medical system, and of patients in terms of, regular preventive care and expecting, healthy outcomes.
And of course, that kind of preventative care reduces costs in the long run, right? I mean, most of the things that we see in the hospital are complications of underlying health conditions that have simmered for a long time, whether it's diabetes or hypertension, cardiovascular disease. So the real way to reduce cost is to expand access and restructure the way that we deliver healthcare such that we can prevent those kinds of complications.
Yeah, you're talking about health costs. And we're also in this study hoping to look at the economic costs and savings of both, that intersectionality of health costs, of delayed care, and like you say, simmering chronic exacerbated conditions, underlying conditions,
Absolutely.
Untreated conditions. Yeah.
Absolutely. And it's worth pointing out from the cost perspective as well that Medicare and Medicaid tend to care for people with high levels of medical need.
Right.
Insurance works best when you have people in the pool who are not high utilizers of healthcare. And those are the additional people who would be incorporated in a single payer system. So, to one of Representative Aurora's earlier questions about, does expanding the system cripple it? Does it lead to failures in the system? I would argue that it leads to improvements in the system because it increases the pool of people who are insured to include young and healthy people that allow for us to pay for the medical costs of our society as a whole.
Great, thank you. And through you, Mr. Chair, I just wanted to say, what do you think about the sweet spot population of our 3.5 million people in terms of this being an experiment in sustainability?
Oh, I mean, I think that experimenting on the state level is critical. This may be a policy that is best enacted on the national level in the end, but it's very difficult to make those kinds of national changes without state level experimentation. And I think that this is the kind of experimentation that can attract people and that can make a state a really attractive place to move to, especially for young people.
Wow, thank you. Thank you for your testimony.
Thank you, Representative Hughes.
Representative Aurora.
Thank you, Mr. Chair. I really am honored to have the opportunity to discuss and get input from you, Matthew, because you do come not only with a very strong background but also a lot of experience, advocating for this. And by the way, at the outset, I'll tell you that both of us have a similar objective, which is the best care for every single person, every single American. Both of us agree. And I left a private career, just to focus on policy and service, to really make sure that ideas like that, which is making sure that every American has access, each one of our citizens, is a very important thing for me as well. It's just how we get there, right? And my question for you is that you said you were you're going to be in residency at the Yale School of Medicine. Now, is that right? You did. That's what.
No, I'm actually going to be at residency at Massachusetts General Hospital. So
Mass General. Wow, you got both Harvard and Yale on there. Excellent. Congratulations. Right. As they say, that's the max success story of America, Yale and Harvard on the same resume. My question for you is that, have you spent a lot of time studying economics? I know you've studied medicine quite extensively. Have you studied a lot of time studying economics and how typically systems, single systems or competition works?
I certainly would not call myself an expert in economics. I definitely have spent some time thinking about healthcare economics because I care about these questions and I care about how to deliver care effectively to as many people as possible.
Thank you. I really appreciate that answer because, many of us have spent a lot of time studying and practicing economics. And one of the things which we really think never leads to right answer is lack of competition. Whether it's insurance business, healthcare business, name a business, and I'll tell you, including colleges, if there were only one college, and eventually when you study about NHS and other places, do you really have any strong reason to believe that in your study, and as you have studied some, that by killing all competition and aggregating it in a one single payer system would be a right answer when the history of organization, industrial organization and economic organization tells us that when you kill competition, you kill quality, you introduce corruption, you introduce all kind of gaming. And that's what we really seen in many, many systems. So my question is, do you have any experience or insight or that why killing all competition or pluralism, as we call it, pluralism in discussion, pluralism in our systems is good for us? That's what you're promoting.
I would ask you whether you think that there's really competition in our healthcare system. I mean, a true competitive market requires transparency and it requires agency on the part of the consumer. Sorry
to interrupt you. I agree with that. We need to improve our system and we need to make our competition better. There's no disagreement between you and me that competition should work better. Well, my point is, should we kill all competition and make it one? There are two ways to make competition better. One is basically actually work at it. And the second is what you're suggesting, kill it all and have the government control it. So my question
is, Senator Lesser, I'm going to interrupt here as the co-chair. I think this conversation is not really helpful, this back and forth here. If you, the quorum of this committee is to ask questions. So if you have questions that are going to lead to a different outcome, this bantering back and forth, I don't believe is effective in this committee. So if we can stay on track, I would appreciate that.
And Senator Lesser, I would agree, but it needs to be for all people who are asking questions or giving opinions. Thank
I
you.
agree.
Well, thank you. So I'll just restrict my question to, do you think a competitive system works better relative to a system which has no competition?
In healthcare specifically, I do not think that a competitive system works better with respect to health insurance. That does not necessarily mean that there can't be competition at other levels of the healthcare system, for example, at the level of healthcare delivery. But in terms of the health insurance level, I don't actually think that in the healthcare system, the type of competition that we have in our system is better than having a single payer that can appropriately structure incentives.
Okay, so you think, as you say, what I'm hearing you say is that insurance is a separate case, whereas in other parts of the healthcare system, it may work better. Okay, and finally, let me ask you one last question here. You mentioned that overall, a universal system would work better, right? Would you care to really comment on, or have you studied perhaps any of the other international systems like the NHS, which we heard earlier about, or Canada, if you had any insights as to why they have failed miserably? Because as I had pointed out, one of my personal stories, I grew up in India and I hated the public system because I had horror stories about it. It also started well and ended up being very poor, and it's a private system now. So I just wanted you to see if there are any insights we could get if you had, having advocated for a single payer.
I would just make two comments. One is that there are many different models, some of which, having a single payer doesn't mean that that payer has to employ the physicians. So that's a distinction between a single payer system and the type of system that you're describing in some of these countries. So it doesn't have to look like any one of these individual countries that you've cited. And the other thing I would say is that I disagree with the premise of the question that they failed miserably. I think healthcare outcomes in a lot of these countries are much better than healthcare outcomes in the US. So it's only looking at a subset of the population that you could argue that the US healthcare system is better. For most people, those healthcare systems, unfortunately, actually deliver better care for them than the US system, which I think is a problem.
Have you lived abroad to say that?
I've lived in England, actually.
Oh, great, thank you. I think that really provides a great counterpoint to what I'm saying. But having lived abroad in several places, I found that government systems have failed miserably. But maybe that's just my experience. Thank you very much for your time. I really do appreciate it. I know I'm going to get cut off here, so I really appreciate your to and fro, which obviously we're going to do a little less of. Thank you, Mr. Chair.
Thank you for your time as well.
Thank you, Representative, and thank you, Matthew. Next up, we have Daniel Bryant, followed by Karen Siegel.
Thank you so much, Senator Lesser. My name is Daniel Bryant. I appreciate you taking the time to listen to me today. I come to you today as both a patient and a healthcare provider. I'm a licensed professional counselor. I've been practicing here in the state of Connecticut for 10 years this year. And I work at one of our largest community health centers, delivering care to mostly Husky insured patients. On the provider side, it is important to understand the gaps in the system that we currently have and the ways in which this will help to seal some of those gaps up. I have countless patients who are working poor, trying desperately to get their lives on track, and they get a slight pay bump and find themselves thrown off of Husky through no fault of their own, and then are either outside of the realm of enrollment for the ACA, or just quite frankly can't afford it because the plan is not nearly as comprehensive as Husky is. Husky is a system that is really quite comprehensive and excellent, and patients are grateful for, and I am proud to provide care under. And with few exceptions around specialists, it meets almost all of the needs of patients fairly universally. As a patient, I'm a type 1 diabetic. And when I first finished grad school, I moved to the state of Massachusetts, and I was able to get state insurance that I paid for and contributed to in a way that made my life affordable and survivable. It was a brief period where I was uninsured, and the state's program, which had not just one, but two different choices to choose from that were state funded that I could buy into, provided excellent insurance at a fair and reasonable price without all of the challenges that were presented to me in the ACA or in other places at the time. This program will do an awful lot for the citizens of this state. I am proud to work so closely with the Husky Health Insurance Program, and I am hopeful that something that resembles that will be what is generated from this bill, as it is a system that we should all be proud of and seeking to expand access to, even at a cost.
Thank you, Daniel, for your testimony. Have you seen well, I was just curious if you'd seen a change in demand for your Husky patient base since the onset of the COVID pandemic. Is there a change in the mix of your patients?
A change in the mix, meaning
Husky versus I mean in a
yeah, our
health center
paramedics,
setting. I don't even know if you know
our paramedics has stayed fairly consistent during the course of the pandemic. There's been a slight uptick in Husky, but not by much, and a slight uptick in uninsured, but also not by much.
Thank you. Are there questions or comments from members of the committee? If not, thank you very much for your testimony.
Thank you.
Next up, we have Karen Siegel, followed by James Bhandari Alexander.
Good afternoon, Senator Lesser, Representative Abercrombie, esteemed members of the Human Services Committee. My name is Karen Siegel, and I'm testifying today on behalf of Health Equity Solutions, where I serve as the Director of Policy. Health Equity Solutions is a nonprofit organization with a statewide focus on promoting policies, programs, and practices that result in equitable healthcare access, delivery, and outcomes for all people in Connecticut. I appreciate this opportunity to testify today in support of SB 1090. As many of you have heard me say in recent weeks, health insurance is a necessary part of health equity, and this study could develop a plan for ensuring that all Connecticut residents have access to health insurance that they are able to utilize. In order to ensure that our priorities are community informed, Health Equity Solutions conducts annual listening sessions, and this year, despite conducting them in the midst of a pandemic, one of those top two concerns was healthcare affordability. We believe that Husky programs are a good basis for the study of universal healthcare program because they offer a comprehensive health insurance. So they cover dental and mental health care and access to a comprehensive set of services because they cover care across the lifespan and they are quite fiscally efficient. We respectfully recommend that the study include analysis of the program's potential impact on disparities in insurance coverage by race and ethnicity, which are currently quite large in Connecticut, and barriers to enrollment and utilization of health insurance that disproportionately impact people of color, including not only premiums, but other out-of-pocket costs and the processes involved in enrolling and in renewing coverage. Given the work that's been done in other states in recent years to address affordability, we believe that there's ample opportunity for this study to draw on lessons learned in other states, particularly around whether or not those programs have reduced disparities, and to provide real insight on both the costs and ability of the program to mitigate uninsurance disparities in Connecticut. I also noted recently that even with the new increased premium subsidies through the American Rescue Program plan, a household of four covering just the two adults would still face $5,000 in out-of-pocket costs if they needed to actually use their health insurance. So a host of research demonstrates that out-of-pocket costs cause people to forego or delay the healthcare that they need, and this is particularly worrisome in a pandemic when we know people are already delaying care for fear of contracting COVID. So thank you all for the opportunity to speak with you today. Happy to take any questions.
Thank you, Karen. And I think there may be someone else who's testifying as well.
Rafi is trying to break in.
Oh, excellent. I've certainly never been there. Well, thank you. Had just a technical question. I'm not sure if other states have looked at the specific. I mean, the majority, as I understand it, the majority of the insured population currently gets its insurance through self-insured ERISA plans that would be beyond the ability of the state of Connecticut to regulate one way or the other. and I was just curious if there was an equity lens to, in terms of which percentage of the Connecticut population gets its health care through an ERISA employer-sponsored plan versus not. I don't know if any of the states that have been looking at similar proposals have looked at that specific question.
That's a really great question, and there is not great data on it that I have been able to find. We do know that there's a little bit of data gathered by folks like Kaiser. In Connecticut, I haven't been able to get a race ethnicity breakdown, but I believe that that may be part of the analysis that was just done by Access Health. And if it isn't, it will be part of the research being done by a couple of the groups that have been working on other insurance options. So the short answer is that's not data I can give you right now, but it should be coming soon.
Okay, thank you. Questions or comments for Karen Siegel, members of the committee? If not, thank you for your testimony this afternoon.
Thank you. Take care.
You too. Next up, James Bhandari Alexander, followed by Carlos Marino.
Good afternoon, everyone. Thank you for hearing me. My name is James Bhandari Alexander. I'm the legal director of the Medical Legal Partnership at the Solomon Center for Health Law and Policy at Yale Law School. Having said that, I am not a health insurance expert. I'm a legal aid lawyer. We provide civil legal services to low-income patients in medical sites of care. So in our program, I'm supervising law students and working with patients from a variety of different patient communities, including veterans, people in palliative care, cancer patients, geriatric patients, uninsured immigrants, and people coming out of incarceration. And each patient community has different needs in terms of health insurance. What I want to do is just describe a little bit of what I'm seeing and in support of this proposal for a study. What I see similar to the medical care provider from the community health center is that there are a lot more gaps in coverage than people realize, even for low-income people. And I think one of the most dramatic examples is for people leaving incarceration. They often have a lot of trouble getting onto Husky, even when they, by all appearances, qualify. In fact, it has to do with federal Medicaid, and there's a fix at the federal level to try to allow people leaving incarceration to actually apply and be granted health insurance at the end of sentence. The fact that this is required for these people to get health insurance, I think gives you a little glimpse into how fragmented and nonsensical this complicated health insurance system of ours can be for our most vulnerable people. Of course, for uninsured immigrants who have no access currently to public health insurance, the problem is very straightforward. At no point until they're able to succeed in their immigration applications, at no point will they be receiving any public health insurance. So the health effects are very bad. And I can contrast it with the veterans that we serve. The veterans are in not just a single payer system, they're in a national health system that they're very satisfied with in general. Are there horror stories? Yes. We saw them a few years ago in Washington, D.C. There was an entire investigation, an important investigation that uncovered all kinds of problems. There are problems, but the average person at the VA is in a lot better position than people from my other client communities. Having said all that, and with the caveat that I'm a strong supporter of a federal Medicare for All bill, I come into this conversation grateful that you're looking at a study, because I don't know a lot about what it would look like to have a single payer health insurance at the state level. And I think some of the questions that have been raised are really valid. Questions about how it would work. And I would suggest that you add into your list of things the commission could look at the effect on municipalities that are facing extreme problems right now. Help that could be providing more services if, as an employer, they weren't they weren't paying such high prices for health insurance. I would also ask for you to include more consumers in who's included on the commission.
Excuse me,
I think
excuse me, sir, your 3 minutes are up. Please summarize.
Yes, so in summary, I support this study. I genuinely support this study as of somebody who does believe in single payer on the national level as a way to answer the questions that people are putting forward about how it would affect us at the state level.
Thank you, James, for your testimony and for those suggestions. I agree with you. If this proposal were to move forward, it should address a lot of those questions. And, earlier I'd asked Karen Siegel just a sort of a basic question. I thought about how this could work intersect with ERISA plans, and I don't know the answer to that, but I think that someone should figure that out if this bill moves forward. Are there questions or comments for James from members of the committee? If not, thank you for your testimony. It's good to see you.
Thank you all very much for your time.
Next up, Carlos Moreno, followed by, well, the next person we have up is Rana Stoller. I will say that we've skipped over quite a few people who've signed up to testify who we have not seen here. So if any of them appear, we may be able to return to them. Carlos, you're up.
Great. Thank you, Senator Lesser, Representative Abercrombie, and members of the Human Services Committee. My name is Carlos Moreno. I'm the State Director, Connecticut Working Families Organization. We stand in support of SB 1090 as a pathway to a statewide universal healthcare system. Rising healthcare costs are a major economic threat to Connecticut residents. Over the past 15 years, families saw the cost of healthcare in Connecticut rise by 77%. It's much faster than the median wages at 21% and greatly reducing disposable income. As of 2018, family coverage averaged $20,735 a year in Connecticut, and that's consuming 28% of median household income, with projections for healthcare costs to continue to rise significantly faster than inflation. So if you consider that 40% of Americans wouldn't be able to afford an emergency expense of just $400, it's no wonder that unpaid medical bills are the single greatest cause of bankruptcies for Americans. In the US, about 2/3 of personal bankruptcies have been medical cost related, and when you factor in that cities like Bridgeport and Hartford, where 73% and 66% respectively of the population live just one paycheck away from poverty, it's clear that the crisis required bold action way before COVID even hit. But the pandemic has exacerbated existing economic and healthcare inequalities, and the loss of jobs among people of color has led to a health insurance loss that's approximately double across the US, with immigrant and Latinx populations experiencing the most disproportionate impacts. So we're at a moment that seriously merits the study of a statewide single payer system. Our healthcare system, as everybody knows, is extremely fragmented, requiring that patients navigate through a patchwork of care systems, coverage plans, and varying costs. And it's clear why administrative costs are so excessive in the US, and that's at about 24% of healthcare expenditures overall. A single payer system would ensure that most healthcare dollars go to patient care, not the cost of doing business or profits for executives. Several states have been pushing forward with studies to assess the benefits and impact of single payer state level systems. And study after study has shown a common thread and determined that net cost savings and or increases in household income overall are really what stands out. A few examples, I'll just pull out a few examples. Those are three. One in California, a study estimated that overall costs of providing healthcare coverage to all under a proposed program would fall by about 18% relative to spending levels under the existing system. Those savings would be achieved mainly through streamlining administrative functions, restructuring pharmaceutical pricing, and fee structures for service providers. In Maine, another study showed that a proposed single-payer system there would affect most families positively. Those in the bottom 80% of households based on income would experience a boost in household income as a result of the proposed single-payer plan. For middle-income families, the average income gain would have been $3,500 per year and that's 8% of the annual income. In Georgia, another study, research found that the proposed single-payer program there, Secure Care, would achieve universal coverage while actually reducing healthcare spending for Georgia by about $716 million. The primary source of those savings would be reductions in the cost of administering various health insurance programs and savings through bulk purchasing. So my testimony includes a link to a site that includes studies from 14 different states that have examined this issue. I encourage everybody to check it out. And lastly, we'd like to make the following recommendations respectfully to the parameters of this study. One, we asked that a health equity impact analysis examining coverage by race and ethnicity, as well as barriers to enrollment and usage, take place. Two, ensure that undocumented immigrants are included in the analysis of uninsured persons. And three, a feasibility study with recommendations for training and transitioning the private insurance workforce to a single payer system workforce. We're clear-eyed that there are no shortcuts.
Excuse me, your 3 minutes are up. Please conclude your testimony. Thank you.
Thank you. And the biggest barrier to state level and universal health care are insurance companies themselves. So I urge this committee to take this important step and support SB 1090. Doing so will acknowledge the universal health care is a fundamental value for Connecticut. Thank you.
Thank you, Carlos, for your testimony. Representative Dathan, followed by Representative Aurora.
Thank you so much, Mr. Chairman. And thank you, Carlos, for your testimony today. It looks like you did quite a bit of research and brought that to the committee, which is we're all really grateful of. One question I had for you was the composition of the commission. I mean, you've worked in the building a little bit and know your way a little bit around the legislature here. And I'm just wondering, do you have any suggestions or insight for the commission to make sure that you feel like it runs smoothly? Because my always concern about establishing a commission or a task force is sometimes things get lost in the shuffle. And this is a really important study to me and want to understand, you know, the results. Do you have any suggestions or input on that?
Yes, thank you for the question. I would recommend three specifically. One, that there's somebody qualified to provide an analysis of health equity, someone from Health Equity Solutions, perhaps. Two, someone that would be focused on the consumer impact here. And three, I would say someone that's involved at the ground level of community clinics that really has experience administering patient care to the undocumented population. As we know, a lot of those folks depend on community clinics because they have nowhere to go. And a lot of these community clinics don't provide a comprehensive level of care. There's just certain kinds of specialty care that's needed that folks have to forego. So those are the three that I would recommend.
Great. And my second question is in regards to the 14 other states that you talked about. What sort of studies or commissions or task forces have those states done in order to evaluate this for their states?
Unfortunately, I don't have that answer for you, but I can get it.
That would be great. If you could please forward that to our clerk, that would be phenomenal. The administrator's name is Heather Ferguson Hall, and you can just contact her through the CGA website. I'd appreciate that. Thank you, Mr. Chair. Thank you, Carlos, for your testimony today, and thank you, Mr. Chair.
Thank you, Representative Dathan. Representative Aurora.
Thank you, Mr. Chair, and thank you, Carlos, for your testimony. I have a couple of questions. One is when you said that a universal system healthcare coverage would really improve is needed. There are three elements which perhaps you could expound on. One is it that it's too costly or expensive, or has too high, co-pays and so on? Second, do you think it's a quality issue, which can be improved by the single payer? Or do you think the single payer, you would like a single payer because of access, that there are pockets of people who do not have access? Which of the three do you think, or all of them, would you like to, would you find really problematic with the current, as somebody called a hodgepodge system?
I think the first, thank you for the question, Representative Aurora, I appreciate it. I think the patchwork of care, the number one barrier right now that I think to usage, especially among Black and Brown populations, is unfamiliarity and the difficulty accessing the system. It's a patchwork of care. It's very confusing. It's very intimidating for folks to be able to get a foot in the door and understand where they need to go. The cost of care is probably the second barrier after you get that first one. The current patchwork of care is just too costly for folks, right? You know, I think that the ACA was an important step forward in expanding care to millions of people and capturing a lot of folks in the coverage gap, but it didn't fundamentally address the way that healthcare is delivered in this country through the private insurance model. While it was an improvement, it still helped reinforce some of the negative aspects of our system, and that is the lack of control over pricing that affects everything from co-pays to, you know, pharmaceutical drug prices, you know, co-insurance, all those sorts of things. So, you know, that's an aspect of our, you know, free market system that we have in this country that we have to contend with and rectify at some point. That's the second major barrier. What I think about, and then to get to your second point, the quality issue, I think that the Husky for All is a good example. I've never had experience with Husky. Fortunately, you know, I've been in a position where I didn't need it. But from friends of mine and folks that I do know anecdotally, I know that they've always been pleased with the service. It's been very straightforward. Going through the website when it is working has been a positive experience for folks. I know that we heard from someone that had difficulty with that earlier today. And the connectivity to care at the clinic level has always been pretty streamlined and seamless. You know, after navigating through the website and establishing contact with a medical provider and then getting in the office and getting that quality care in a face-to-face setting, I've heard nothing but great stories. So that's why I'm advocating for this study to examine the impact of expanding this as a universal healthcare system in Connecticut.
Right. Just a follow-up question. You said, well, it's the delivery system which is in our country, which has a big problem. And when you say the delivery, you don't mean to say that it is the doctors and the hospitals and the delivery. When we, you know, in healthcare, when we think about delivery and provider system, we think about, you know, the hospitals and the doctors and the surgeries and the surgeon centers and so on and so forth. Whereas when you think about the payer, you think about the insurer or the Medicare and so on, and they are all, you know, in some sense connected together. So is your problem primarily with the payment process and the risk mitigation progress, or are you saying that you have a big problem with the entire provider system as well?
I think my problem would probably start with the way that fee structuring is created in the state and the lack of power or role of government in having a hand in fostering more competition to drive prices down. You know, I would encourage you to support the public option bill if you're concerned with fostering more competition in the private insurance marketplace. But I think that is where the first point of contention is. I believe our doctors are doing the best that they can with a patchwork system and experiencing a lot of the same negative aspects that patients are. I think they are coming from a good place and trying to navigate the system to the best of their abilities, but also frustrated, as we've heard from doctors already today, with the restrictions that have been imposed upon them in terms of managing patients the way that they feel would be most effective. I think we heard from Mr. Meislish to that effect.
So your experience is, your basic concern is with the pricing process, and you would like a system which would have more pricing through competition, or, you know, if the state takes over, it's basically just the state setting the prices. Yes. So that's the worry. You have to realize that the reason we don't support the study is because we think a big study was done over 40 years, and we call it the study after the Second War of two systems: a system of central planning, which was done in real time in 3 countries, and the system of free markets, which is always a patchwork of competition. Looks like a patchwork, but it's competition, and the regulator's role. And this is a comment. This is not a banter, please. This is a comment. And they,
Representative, I understand your.
I think a comment is allowed, or now comments are not allowed either.
If you could confine your questions to the bill before us, that would be helpful. Thank you. Thank you.
Right. This is we are talking about a single payer system, which is really, and that's the reason we believe that you know, single payer system is reflective of one central controlled process planning, and it is really prone to gaming and corruption. So from my perspective, I just really ask you that, perhaps it is the cost, quality, and access which needs to be improved in the current system. And it's not throwing away the entire competitive system which is at stake. So, I guess that's just a comment, not a question, and that's where I will leave it. Thank you very much. Thank you.
Thank you, Representative Aurora. I'll give you one example of a good centrally planned system that has great, internationally world-renowned healthcare, and that's the country of Cuba. It's a communist country. That aside, for their socialized healthcare system is world-renowned, and their doctors travel all over the world to provide medical care on a short budget. And the main problem with their access to medical equipment is probably the American embargo on that country that prevents that country from achieving a higher level of quality of care. So I want to push back on that a little bit. I think that central planning in that country actually does work. And I have a Cuban American background. I have some experience on the family side with understanding that system there. So I can feel like I'm a little qualified in saying that. Not all of it is bad. But my second point to that is just purely from a philosophical level, any health model that is presupposed on a profit-driven basis is probably not gonna probably does not have the consumer it probably does not prioritize the consumer as the first order of business.
Well, thank you very much for your input. I would not take Cuba as a role model any day because of the amount of atrocities which go on there. But on the other hand, and I also would not agree that anybody who's making profit does not serve their customer. People serve their customers and make some profit. That's our system. And there's nothing wrong about that. It is a good system. I'm sorry, I do not agree with you that a system, anybody who makes profits is bad. I just don't. Thank you very much, Carlos, for your input, and thank you, Mr. Chair.
Thank you, Representative Aurora. At this point, I'd like to hand over the controls back to my chair, Senator Moore, who I believe has joined us again. Or not. We can hand, Representative Wood, do you have a question?
I am going to apologize. I was muted. I said, are there any more questions? I guess Representative Wood does have a question.
Yes, I do. Thank you, Madam Chair. And thank you, Carlos, for your testimony. I have a question. You mentioned that the role of government is to create more competition. In your view, how would this happen in this type of healthcare situation?
No, thank you for the question, Representative Wood. I think the role of government is to acknowledge that healthcare is a human right and to deliver healthcare absent competition to its citizens. But I'm clear-eyed and understand that there are certain elements in this country that have put us where we are, and we have to contend with the private insurance business model. So my question about competition, if we're so worried that single payer is going to decrease competition, then the example that I gave to Representative Aurora is, then why are we then? Logically, there should be more support for the public option bill, which would create more competition with the private insurance industry and seek to expand care. The private insurance business model has not worked. I mean, there's 187,000 people currently without insurance in Connecticut. Some of them are undocumented. A lot of those folks also fall in the coverage gap. They can't afford qualify for Medicaid or afford private insurance or plans on the exchange, right? So, what are we doing about them?
So you did make the statement, though, that government should create more competition. So to give me one sentence answer on why you said that, it would be.
One sentence
answer. You did make that statement that the role of government is to create more competition. So I was just questioning you on exactly what you meant by that. I'd like to understand.
I believe that I meant that in the context of the public option bill. I don't want to get off topic, but that is a bill where the role of government would foster more competition in the insurance industry. If we're talking about single payer, we're talking about another subject. We're talking about the government's role in providing care to all of its citizens.
All right. Thank you very much. Thank you, Madam Chair.
Thank you. Any other questions? Seeing none. Thank you, Carlos.
Thank you, Senator Moore.
Up next is Magana Fernandez. Is Magana here? If not, I'll go to Rona Stuhler, and if Magana comes back, I'll call her back. Rona, how are you?
Thank you, Senator Moore, and thank you to members of the Human Services Committee. My name is Rona Stuhler. I live in New London, and I support Senate Bill 1090. A little over a year ago, in February of 2020, the New London City Council unanimously approved a resolution in support of single-payer healthcare legislation. I was one of the citizen presenters of that resolution, which had broad support among the city's residents as well as elected officials. Even before the COVID pandemic exposed and widened the gaps and cracks in our current fragmented for-profit healthcare system, our city was impacted daily by its failings. For all of the 26 years I've lived in New London, our city has struggled to maintain services while trying not to overtax our residents. The burden of providing healthcare insurance to municipal employees and retirees makes this a nearly impossible task in cities like New London, where a large amount of our land is non-taxable and limits our opportunities for revenue. In fiscal year 2020, health insurance premiums cost New London over $13 million, about 15% of the budget and a line item second only to wages. That year, our Board of Education had to adjust for a surprise 29% increase in the cost of premiums, resulting in reduced programs while adding no value to employees or to families in our community. According to estimates made at the time the resolution was being considered, about 9 mils of our high 39.9 mil tax rate went to health insurance costs. Husky for All offers the potential for significant savings, and Connecticut municipalities need the study authorized by Senate Bill 1090 in order to determine much more accurately than our estimates can how a state single-payer healthcare program could benefit our cities. Additionally, the current system's effect on the overall well-being of our community goes far beyond its obvious budgetary impact. As our region's urban hub, New London provides much of its safety net services. People forced to choose between buying food or medicine come to our meal center or and food pantries. Those whose spousal insurance benefits keep them in abusive relationships may utilize our domestic violence support centers. Those who lose their home or savings due to medical debt may find themselves in our shelters. And those who delay routine medical care are likely to end up in our hospitals' emergency rooms. For these reasons, I urge the Human Services Committee to approve SB 1090 and also ask that the study include data on the trickle-down impacts of our current system on municipalities, employers, and individials. And I want
Excuse me, your 3 minutes are up. Can you please summarize? Thank you.
Yeah. One last statement. As a senior citizen, I have to disagree with the statement that we love Medicare as it's currently administered. There are many things it doesn't cover, like dental and vision care. I'm lucky that I'm also covered by Connecticut retiree insurance. And between my two public insurances, I have good coverage. Husky for All would allow that kind of good coverage to everyone in our state. Thank you very much.
Thank you, Rona. Appreciate your comments. Are there any questions? Representative Hughes.
Thank you so much, Rona. You said something about the New London 13 million cost in the line item to insurance. And you said something also about without adding any value. And I thought that is an incredible point that we hope that this study will look at. What is the value of not having to review every year and compare plans and just know that this is a service that's going to be covered and paid, not by you getting denials, but by, you know, by it being submitted to someone else that is just going to pay it.
And it is huge. And I mean, when I wrote that sentence, really partly what I intended was that with the 29% increase in insurance premiums, no one thinks we got a better policy out of it. Our employees did not get better insurance policies. They did not get lower deductibles. They did not get better, more comprehensive coverage. It just cost more. And to think that school programs had to be cut because, our mill rate was already nearly 40, one of the highest in the state probably, that it was really an unconscionable decision, but they had to make it. And I hoped that our Board of Ed finance rep could come today, but he has a day job, so I came instead. But he and one of our city councilors had written an op-ed back over a year ago about the impact, particularly on the Board of Ed budget, which I think was about $8 million of that 13 million that the city spends on insurance.
Through you, Madam Chair, thank you so much, Rhonda. And I believe in the language in the commission study, we do ask for an analysis of impact and savings on municipalities specifically, which would be a tremendous, a tremendous value to the taxpayers of all municipalities if we could shift some of the savings into direct services and amenities of those towns.
Thank you for including that.
I'll double check. I think so. I'll double check, but I believe that we added municipalities to the language. Thank you. I don't have any further questions.
Thank you. I don't see any other questions for you, Rona, but thank you for coming today and thank you for taking the time to give us your testimony. I appreciate it. Next is Jamie Myers McPhail.
Hi, good afternoon, Senator Moore and members of the Health and Human Services Committee. My name is Jamie Myers McPhail. I'm a resident of New Haven and I organize with New Haven Rising. I'm here in support of SB 1090, an act establishing a commission to study a Husky for All single payer universal healthcare program. For most of my life, I did not have health insurance. Thankfully, I was healthy, but I did live with constant fear and stress. What if I had an accident? In fact, that happened to me my first semester of college. While walking, I was hit by a fast moving car and I didn't seek proper treatment because I couldn't afford a hospital bill. Years later, when I was finally able to get healthcare through my union and get checked out, but because I didn't treat my injuries when they happened, I now have chronic pain and mobility issues. And yet my experience is nothing compared to the thousands of lives that we lose every year due to lack of care. Our so-called healthcare system is not about health. It isn't caring, and it can't properly be called a system. It is a complete failure for all but the insurance and pharmaceutical industries. This pandemic, which we refer to as the Great Reveal, has shown us that it's not just an individual problem when someone can't go to the doctor, can't get checked up, or can't access proper healthcare. It becomes a problem for the entire community. It also costs more when people have to put off preventive care and then wind up in the emergency room for treatment when an issue has become life-threatening. It costs more not only for the individual and the family, but for the whole system. We are past the point where we can financially, morally, or from a public health standpoint, justify excluding anyone from access to the care they need. Rising healthcare costs are a major economic threat to Connecticut. Over the past 15 years, families saw the cost of healthcare rise by 77%, much, much faster than median wages, which rose only 21%, and greatly reduced disposable income. One of my members, a teacher at a charter school, recently revealed to me that his deductible is $14,000. So all he can do is pray that nothing happens, and he can't rightly start a family that he wants to start. Healthcare attached to specific employment also stifles entrepreneurship and ingenuity and strangles small businesses. This harms our communities and economy overall. We can no longer tolerate inaction or playing politics with people's lives. If we didn't see the crisis prior, then the COVID-19 pandemic and Trump presidency should have ripped the curtain off to reveal deep systemic racism. In the wealthiest state, in the wealthiest country on earth, the injustices in our healthcare system are glaring. Our inequality was already the fastest growing, and now the pandemic has deepened the wide gap between rich and poor. It is time for courage. It is time for bold action. We must tax the rich and foster real equity with every single bill passed this session, starting with this one. Thank you very much for your time.
Thank you, Jamie. Are there any questions for Jamie? Seeing none, I just want to thank you for taking the time to come today and give your testimony. Appreciate it. Next is David Giacarino Jr.
Hi. So first of all, thanks so much, Senator Moore, and the rest of the committee for giving me time to speak. My name is David Giacarino. I'm a lifelong Connecticut resident, and I'm here to testify in favor of SB 1090. I wanted to start with a quick story about the first time in my life I thought there was something wrong with our healthcare system. When I was in elementary school, I had a classmate who was diagnosed, unfortunately, with leukemia. We had some sort of fundraiser for her. I think it was probably a bake sale or something like that. And I just remember asking why? Why are we having a fundraiser? This horrible thing happened. Why are we raising money? And I probably got a pretty simple answer, that cancer treatment is expensive. That didn't sit right with me, and it really hasn't since. So I felt it was important for me to testify today, not just because of my personal feelings about our broken healthcare system, or I should say health insurance system, but because in this broken system, I'm actually one of the lucky ones. I work in biotech. I develop genetic tests in an R&D lab, and I've had steady employment and what we call good insurance for about 13 years now. Even when I was laid off for 3 months, I was lucky enough to not lose coverage, although I did get to see the eye-popping costs associated with COBRA. And I've been relatively healthy, so you'd probably ask, why would I want to see an overhaul? Well, going back to my work, we do a lot of genetic testing related to cancer, and I've seen how much our personal health can rely basically on luck. A single molecular mutation can upend your life. And when that happens, the last thing you should have to worry about is whether a private company will decide you're worth the cost of the best treatment available. And even if you're healthy, the bar for what we call good insurance seems to get lower every year. Every year in open enrollment, I have to make that decision. Do I stick with a higher deductible plan? Do I pay more in premiums up front? What's going to happen? So to go to this good insurance and friends and coworkers, I've seen over the years, $10 copays turn into $50 copays. I've seen a plan with no deductible turn into a plan with a $1,500 deductible. I've seen family members leave accidents with $5,000 bills, $10,000 bills. And I even have a coworker who was joking for a while that she still owed money for her baby because she left the hospital with a payment plan for her firstborn child. But still, I am one of the lucky ones. I ran for state representative last year in my district here in East Haven, and I met a family that reminded me of that. Their insurance plan had a $16,000 out-of-pocket maximum. Through a health scare and a badly timed accident the year before, they actually had to pay that on top of their premiums. I can't really comprehend how that is a reasonable amount of money for a working class family to have to hand over on top of the premiums that they're paying to this private insurance company. So I support this bill because single payer health insurance, I think, is the only honest way we're going to get out of this mess. And people like me who support this on a broad level, I do support a federal single payer change. We're realistic about our chances in Washington.
Excuse me, your 3 minutes up. Please summarize. Thank you.
There's so much money lined up against it, but unlike in Washington, our legislative campaigns here in Connecticut are publicly financed. So my feeling is if we can't get substantial reform done here, I'm not sure how we'll get it done anywhere. With that in mind, I sincerely hope this committee will support SB 1090. Thank you.
Thank you, Mr. Yacarino. Are there any questions for Mr. Yacarino? I don't see anyone's hand raised, so I just want to thank you for taking the time during the day to come and talk to us and give your testimony. Have a
No,
good day.
Thanks so much for having me, you too.
You're welcome. Number 22 is Rebecca Vergara Greno.
Hi, yes.
Hi, Rebecca.
Thank you for having me here. So hello, Senator Moore, Representative Abercrombie, and members of the Human Services Committee. My name is Rebecca Vergara. I'm a student at the Yale School of Medicine, and I also co-direct the student-run free clinic out of Yale University called Haven. And I'm here to stand in support of SB 1090. And so I'll be speaking mainly from the perspective of someone who's serving uninsured populations in New Haven. And for a variety of reasons, we see major gaps in our current system that I think this bill is important to explore. And so in our clinic, the largest barrier for coverage is legal status. Many immigrants are barred from signing up for Medicaid, receiving subsidies on the marketplace, and otherwise the health insurance plans there are cost prohibitive. And we also have patients who make a little bit too much money for the income limits at FQHCs. So a personal narrative of mine is a patient that we saw a couple of weeks ago. She had concern of postmenopausal bleeding. We did a study that was concerning for endometrial cancer. And so because our clinic was not equipped to handle that sort of care, we referred her to a local FQHC, and she didn't qualify for a sliding scale. They told her that she would have to pay $350 for the visit, and she just didn't go. And so that is the kind of story that we see quite often, especially for those who are just barely over those income limits. And other patients of ours we see that are self-employed, or they work multiple jobs part-time and don't qualify for their company's health insurance, or simply there's citizens who just don't qualify for Medicaid because and they aren't able to afford the plans on the marketplace because they have too many expenses for them to pay for health insurance. And then lastly, we've just seen the incredible impact that a pandemic can have on health insurance, and many of our patients we've seen lose their jobs and thus their coverage, and leaving them without any ability to pay for their care. So what we see is just, as many people here today have said, a patchwork of solutions at every step of the way for every service an uninsured or underinsured patient needs. They have to go through another bureaucratic process or are barred completely. And so the consequences of the system is that people just delay their care until the point where it's an emergent situation. And that often ends in a large hospital bill, which many people cannot afford, and that cost is taken up by the hospital systems and the state government. So I stand in support of this bill to explore the extent of this broken system and helping bring us, one step closer to a more equitable system. And I'm also here to advocate for very clear language in the bill to study the impact of single payer plan on all residents of Connecticut, regardless of immigration status. Immigrant communities have been systematically excluded from most state programs, and if this bill is striving to assess how we can get to universal coverage, no person in the state of Connecticut should be excluded.
Excuse me, your 3 minutes are up. Please summarize. Thank you.
Yep, so that was pretty much it. Thank you all for the opportunity to speak today, and I'm happy to take any questions.
Yes. Thank you, Rebecca, for your testimony. And I do see someone, Representative Dathan.
Thank you, Madam Chair. Welcome back. Rebecca, thank you so much for your testimony today. It's really insightful. I was curious to see how many physicians and people in the medical profession coming out today in support of this. And I think you raised a lot of good points. We've seen it in front of this committee in previous years, how people with relatively simple, what could have been a simple office visit because it wasn't diagnosed and the person didn't go to see a doctor or even go to the emergency room, delayed the treatment only to cost, you know, several $100,000 down the road. And it's really curious how much of that, and I think a lot of people don't quite understand that we taxpayers, you know, do pay for people who are uninsured, and the hospitals do have to cover the cost because of the Hippocratic Oath to cover and to work with people. And I think, you know, that is, it seems like it's forgotten. In terms of studies that you might be familiar with, is there anything that you could, any data? I'm a data person, so I'd like to know if you are familiar with any studies that really investigate the delaying cost of healthcare.
That's a great question. I can only speak from my personal experiences. I think there's a couple studies that came out from Yale a year or so ago about assessing single payer, but I think that was more at the national level, but it was from 2 researchers out of Yale University. So I guess I would suggest that study, but aside from that, I apologize. I don't really have that experience in the data aspect.
So it's more anecdotal. Yeah, and that's a lot of the stories I've heard, you know, in front of this committee and in front of other committees, that it is all, but I just do find it curious that, you know, so many medical professionals are supporting this, which makes me wonder, you know, why more states aren't doing this. What is the true cost? In terms of medication for people, do you also find in your practice that people avoid taking medication or titrating down medication, or kind of reserving medication for other instances because they can't afford the cost of prescription drugs?
So yes, that would definitely be one of the top reasons why we send someone to the emergency department, is because they were either hypertensive or diabetic patient and they just didn't have continuous supply to that medication that they needed. And so they come to us with, you know, blood sugars up the roof. And so we have to send them to the emergency. That's the only option. We can't just take care of them in the clinical setting. So yeah, that's definitely an experience, even despite, you know, 340B pricing in FQHCs and other community clinics. A lot of drugs are still cost prohibitive, and especially now during the pandemic when people can barely scrape together enough money for rent. We've seen the impact. We've actually had to take on paying for our patients' medications. So that's a significant portion of our clinic's budget now because of the pandemic.
Sorry, my dogs decided to have their say. They're very upset about the cost of prescription drugs as well.
In regards to the lack of data, I think that's the reason for this important bill to be to move forward. So that way we can get more state-specific data, regardless of what the outcome of that data says. There's a severe lack of data, I think, overall.
I am hoping that your situation does improve with the insulin bill that we did last year, and I will hope that, you know, that will help improve some of the outcomes that you have for your patients in your office. And I do hope that we can find some solutions to help with, you know, these other medication costs, because it is cost prohibitive, and it's the one thing I worry, well, one of the things I worry about a lot when it comes to healthcare. Thank you so much for your testimony today, Rebecca, and thank you, Madam Chair.
You're welcome. There is a hand up. Representative Aurora.
Thank you, Madam Chair. So good to see you.
Thank you.
Thank you, Rebecca, for your testimony. I just wanted a couple of questions. Number one, what did you think about, first of all, did you support ACA, also known as Obamacare? And did you think that it did anything, if at all, to help the situation with access or the challenges which we all face and which you see so often?
Yeah, my answers will likely not differ too much from Matt Meislish's answers. And I do think there's an incredible change in the healthcare system due to the ACA and the improvement of what we expect from our health insurance. It's no doubt that, you know, including people who have prior health conditions in the insurance pool. That's just the morally correct thing to do. And I used to work actually as a healthcare navigator for the ACA. So I saw a lot of people who had health conditions who desperately needed health insurance, and they were finally able to access care through that way. And prior to the ACA, mental health care was, almost non-existent in healthcare plans. So there's definitely, a slew of services that the ACA required that health insurance provide, and that has been an overall benefit. There's just still continuing to, these gaps are still continuing to exist. And so we just need to progress forward and find new solutions. Not that we should necessarily throw out what we currently have, but continue to progress forward.
Thanks, Rebecca. The centerpiece of the ACA, which costs really money. The other things were regulations, kind of streamlining kind of what could be covered or not, was the creation of coverage, or of making sure that nobody was left behind through either the exchanges or the expansions. Right. So the exchanges, which is what we really are consider as one of the things which was done to cover everyone, have had a problem of costs, and have a problem that we heard that somebody who's on Husky would basically, as soon as they make enough money of above a limit, they have to buy insurance on ACA, and the ACA plans are just terrible. They're just terrible. And most people don't like them. And if you know that currently pretty much everybody, and for a moment, let's just keep the undocumented citizens aside, or undocumented folks who are undocumented aside, everybody has coverage. Either you're covered through Husky, and if you have over a certain limit, you're covered through ACA, but you have to pay something. And most folks do not want to pay something. Then they wouldn't be covered. So the question which I really have for you is that with the ACA, which was supposed to cover holes, really did not cost $500 billion. And you're saying, well, really the private market coverage helped because we had to take pre-existing out, which is a really good thing. But we're saying is the $500 billion which we spent on as a country on covering those holes didn't help. And so what makes us feel that, taking it in more government control? And I really appreciate, you coming on, because, I'm wondering why you don't, economists from your side do not come on from Yale. It's only the healthcare people who come on. So I really wonder that. But, again, to the question that why is it that is, despite that fact that, the Obama or the ACA has been created, that we still do not have that coverage or acceptance?
Representative Aurora, this is Senator Moore. I don't know what that question has to do with setting up a commission to look at single payer.
Because the single payer is going to kill Obamacare or ACA. It is basically replacing ACA. I do not want something which killed something which was supposed to solve the problem. It is what you're trying to do is set up a commission to kill the single most important, actually your side agenda in the last 2 decades. And I do not.
So what you refer to my side agenda, what does that mean? So, Representative Aurora, what does my side agenda mean?
Meaning the party, your party side in some side. I'm just referring to the fact that as conservatives, we have really wanted to change the competitive market system, whereas, as you say, as the history tells us, there was a lot of opposition on the federal level, not on the state. Obviously, there wasn't a state program. So what we're saying is, why do we not want to kill that with a statewide mandate?
Right, well, I don't think there's a question there, and I don't think you should generalize as to my side, because you don't know where I've been for the last 20 years, or any of these other people. So I would speak directly to the question, but also be very specific in your question. And I don't think Rebecca should be held accountable for where the economists versus the people who see the patients. I mean, everybody has an opportunity to come on here. You could have asked economists to come on and give that piece also. So I I don't think it's for Rebecca to explain
No.
about the economy or the Affordable Care Act.
It's
She gave her point of view and her testimony as to why she believes this should be done. And I think that, in all fairness, should be the question that you ask her related to this bill.
Excuse me, Madam Chair, but there's a lot of questions earlier on that were going against the federal level that were brought up by people who were testifying.
All right.
So
Well,
I'm just saying it's a proper question that he had, but if you were the chair, you can rule it.
But,
But there was
but
a lot of
I don't
questions.
want,
you
I don't
know.
want the person giving the testimony to be on the spot for that. That's what I don't want. That was not her expertise. She came in and spoke as a community person working in a community setting, right? That was her expertise, not the other. I couldn't even tell you, I couldn't even respond to the question that you've asked. So Rebecca just said,
Madam Chair.
we say, I don't know.
Yeah, Madam Chair, I'm not asking putting up her in a spot in that sense, because you have to realize that for most of us, we are thinking on our feet as well. We haven't had time, so some of the comments and the questions are interlaced, and that's for every single, for many of us. So, and again, you don't want me to use from both sides. For many of the members of this committee, is these comments and questions are interlaced because we're thinking on our feet as well. It's not that easy either, because we have extremely intelligent people testifying and giving us ideas and challenging some of the assumptions we may have, which is the beauty of this process. And that's why it works very well.
Well, do you have anything else you'd like to ask her, Representative Aurora?
Yes, I was about to conclude when you suggested that,
All right, well, you can ask her the question, sir.
Pardon me?
You can ask her the question.
Okay, thank you, Madam Chair. I really appreciate the opportunity. To conclude and to gather my train of thoughts here, you do believe that? Would you think that that reforming the system as it exists is not a good alternative to a single payer?
I think that the purpose of this bill is to find more information and to do studies onto what is the best model that the state should go forward. And I don't think having more information is detrimental to that cause. So that is why I'm in support of this bill. It's not necessarily, and it's if we're seeing a coverage that would be more expansive than the ACA, I don't think this is a bill that would necessarily destroy the ACA. It would just expand on the coverage that already exists in a different form. And you can certainly, the arguments that you've come up with, throughout this entire public testimony, I think those are really important points. But I think, the purpose of this commission would be to explore those points more and to ensure that we're not just using, we're using our personal experiences, of course, but also seeing how the data reflects those personal experiences as well. So that's how I see the purpose of this bill and the purpose of this commission. And that's why I'm in support.
Thank you, Rebecca.
I appreciate that, Rebecca. Thank you very much. Thank you, Madam Chair.
Thank you. Any other questions? Seeing none. Thank you, Rebecca. That was the last person that we had on the list, unless Meghana has come on. Is Meghana here?
I don't see anybody else, Senator Moore.
All right, seeing no others, I'm going to end the meeting. I just want to mention that 9 o'clock tomorrow morning, we have a committee meeting. And you all have a great day. Thank you. And I want to thank Matt Lesser for stepping in for me. Appreciate it, and my co-chair.
Senator Moore, we will be doing a caucus for the Democrats at 8 a.m. tomorrow, and the same thing for Thursday before the committee meeting at 9.
Thank you.
Thank you all.
Representative Case, do you want to say anything?
No, I'm all set. We caucused yesterday, so we're all good. We're ready to vote.
All right. Representative Wood, did you have something you wanted to say?
No, just thank you. I mean, yes, thank you.
Thank you. Thank
You're
you
welcome.
all.
Take care, everybody.
Thank
Thank you.
you.
See you tomorrow.
Bye-bye.
Bye.